Good evening, everyone. Thank you for joining us today. We'll get started shortly. Okay, good evening, everyone. Welcome to today's webinar titled HIV, Tobacco, and Cancer, Understanding the Intersections and Impacts. Again, welcome to today's webinar. A few notes real quick. The chat is open if you have any questions. Our Q&A is open as well as we're going throughout the webinar. Also, those that are attending this webinar that are receiving CEUs, more information will be told at the end of this webinar. Today's webinar is brought to you by the Louisiana Campaign for Tobacco-Free Living's Empowering People and Community Series. The Louisiana Campaign for Tobacco-Free Living's Empowering People and Community Series has the mission to equitably bring health education, resources, and hope to the people, populations, and communities in Louisiana by increasing awareness and empowering people, populations, and communities about tobacco and tobacco-related issues. On the screen are our learning objectives. I am Michelle Ozai. I'm the Social Health Disparities Lead for Louisiana Campaign for Tobacco-Free Living, and I will be moderating today's webinar. Now we will have a message from Dr. Nucleus Benjamin Robinson.
Thank you, Michelle. Good afternoon, good evening, and thank you guys so much for joining us today, here live today and in the future on our YouTube page. Welcome and thank you so much for joining us this evening. On this 36th year of World AIDS Day, the Louisiana Cancer Research Center and the Louisiana Public Health Institute, the Louisiana Campaign for Tobacco-Free Living, is excited to bring you this conversation that is centered around not only HIV, but also tobacco use and cancer. Nothing happens in a vacuum. Most things are connected. People living with HIV and those perceived to be disproportionately affected by HIV are also disproportionately affected by tobacco use, vaping, and cancers has a relationship with all of these factors. So this evening, in celebration of World AIDS Day, we want to have an intersected discussion around tobacco use and cancer, specifically related to HIV. So again, thank you so much for being a part of the Louisiana Cancer Research Center and the Louisiana Public Health Institute, the Louisiana Campaign for Tobacco-Free Living discussion. Without further ado, I'll turn it back over to Michelle.
Thank you, Dr. Benjamin Robinson. Now we will see who our panelists are today, and I will read their brief introductions, and then we'll get our discussion started today on this very important topic in conjunction of the observance of World No AIDS Day. First speaker we have is Dr. Tavell Kendall. Dr. Tavell Kendall is a board-certified family nurse practitioner and the director of HIV prevention and treatment at St. Thomas Community Health Center in New Orleans, Louisiana. He oversees the provision of clinical services related to HIV prevention, HIV primary care, sexually transmitted infections, and viral hepatitis. He is a credentiated HIV specialist by the American Academy of HIV Medicine and an advanced HIV/AIDS certified registered nurse by the HIV/AIDS Nursing Certification Board. He currently serves as the clinical director of the South Central AIDS Education and Training Center within the LSU School of Public Health and chairman of the Louisiana Commission on HIV and Hepatitis C Education, Prevention, and Treatment. He is a fellow of the Academy of Diversity Leaders in Nursing, a fellow of the American Association of Nursing Practitioners, and a fellow of the American Academy of Nursing. Thank you, Dr. Kendall, for being a part of our webinar. Our next speaker following Dr. Tavell Kendall is Dr. Charles Wood. Dr. Charles Wood is a Cancer Crusader professor of the Department of Interdisciplinary Oncology at the Louisiana State Health Sciences Center in New Orleans, and the Associate Director of Basic Research at the LSU LCMC Health Center Cancer Center. His significant academic and administrative experience includes serving as a director of a research center, as the principal investigator and co-principal investigator of several active multi-center and multinational collaborative projects. He joined LSU Health from the University of Nebraska, where he held the university professorship and was founding director of the Nebraska Center for Virology in 2000, a COBRE supported center that spans the entire University of Nebraska system, forming the first research network throughout the state. Dr. Wood leads research collaborations and exchanges between different partners in Africa and the LSU SHC. Dr. Wood began his research on HIV/AIDS in sub-Saharan Africa more than 29 years ago in Zambia. These research programs have been expanded to Tanzania with support from the National Institute of Health. He currently directs an active NIH-funded research team studying HIV and Coscopy sarcoma and KS-associated human herpes virus. He is deeply committed to the training and development of the next generation of undergraduate and graduate students and researchers. He also serves as director of two NIH Fogarty International Training and Research Programs with a focus on HIV research and training on the next generation of graduate students and postgraduate research in Zambia, and more recently in Tanzania. Thank you, Dr. Charles Wood, for also being a part of our webinar today. Our next speaker is Samuel Burgess, Dr. Samuel Burgess. Dr. Samuel Burgess is currently the director of the STI HIV hepatitis program for the Louisiana Department of Health, where he has worked in various roles since 2004. Sam began his career in HIV/STI prevention at a community-based organization in 1996 and studied various aspects of epidemiology, research methods, evaluation, and public health interventions to address HIV, STI, and hepatitis-related inequalities during his graduate level studies. Additionally, Dr. Sam currently serves on the board of directors for NASTAD and the Southern AIDS Coalition, and occasionally serves as an adjunct professor for Xavier University's graduate program in public health sciences. Sam has been serving communities most impacted by HIV, STI, hepatitis his entire adult life, and this work still holds his greatest passion and commitment today. Thank you again, Dr. Samuel Burgess, for being a part of our webinar. Last but certainly not least, we have Mr. Morris Singletary. Morris Singletary is a passionate and courageous community development professional, has dedicated his life to advocating for individuals living with HIV. With extensive expertise in HIV peer education, storytelling, social media, and public health, Morris fearlessly uses his voice to educate and empower young Black men who have sex with men, ensuring they receive the necessary care. As a trailblazing social media pioneer and guru, Morris utilizes online platforms to educate and engage a wide audience on HIV-related topics. Having personally experienced the challenges of living with HIV as a Black, gay, Christian man in the Southern United States, Morris's journey from hurt to healing has driven him to support others through his influential social media platform. Positive to Positive, through engaging live chats with guests, Morris not only shares stories of survival, but also inspires individuals to thrive with HIV. Morris's impactful work has gained recognition and opportunities for collaboration. He has undergone GLAAD media training, featured in the Gilead Compass Initiative video, shared his story at national conferences, and established a 501c3 organization as founder and director. Additionally, Morris's powerful storytelling led him to addressed a large audience at the 2019 GLAAD Los Angeles Awards, where he presented awards to notable entertainers Beyonce Knowles Carter and Jay-Z for their commitment to equity. Currently, Morris serves as the executive director of the Positive to Positive Initiative, a transformative organization dedicated to ensuring HIV negative individuals remain negative while supporting those living with HIV to receive equality care. In addition to his role as executive director, Morris also chairs the Metropolitan Atlanta HIV Health Services Planning Council, overseeing the provisions of essential services to the 20 counties surrounding Atlanta. Recently, Morris relocated to New Orleans in January 2023 to continue his impactful work within marginalized communities focused on HIV treatment, care, prevention, and advocacy. As an advocate and activist, Morris, an alumni of Dillard University, New Orleans' oldest historically Black university, has made a personal commitment to college students, ensuring they obtain a degree without the burden of HIV. Again, thank you, Thank you, Mr. Board Singletary, for being a part of our panel. And today we will start now with Dr. Tavell Kendall to start us on a discussion of the impacts of HIV, tobacco, and cancer.
All right. Well, welcome everyone. I'm really excited to be on this panel and have this discussion. Next slide, please. So my goal is to level set us and just kind of get us all on the same page in terms of, what HIV is and why we're here today. So we'll start just making sure that everyone understands the differences between, HIV and AIDS. Sometimes we'll hear a lot of stigmatizing language in our community as it relates to the use of these terms, but I think it's very important to make sure that we are all on the same page as it relates to what these terms actually mean. So human immunodeficiency virus, or HIV, is a virus that attacks the body's immune system. It is a virus that causes what we call acquired immune deficiency syndrome, or AIDS. The goal is to identify HIV as quickly as possible because we don't want anyone to progress to a situation where they have advanced HIV or AIDS. And so to the extent that we can get people tested as quickly as possible is the most important part of the strategy in terms of ending the HIV epidemic, because we need to make sure that we identify everyone who is actually living with HIV. HIV is known as a retrovirus. And again, with an advanced clinical presentation, you can see a number of things. To the right here, you'll see immunosuppression, which certainly can predispose someone to having all sorts of illnesses that sometimes can be quite deadly. Opportunistic infections, malignancy, cancer, and we'll talk a little bit about some of those. And I know colleague Dr. Wood is going to kind of walk us through, some of the things that are a little bit more prominent. Wasting, central nervous system degeneration, and these are all the things that we're looking for, particularly for someone who we don't know how long they've had HIV, to make sure that we identify any of these things as quickly as possible and get them addressed to decrease, morbidity and mortality. Next slide, please. So when we talk about what HIV does, I think it's important to make sure that everyone understands that as well. So HIV essentially likes to use the immune system to make a copy of itself. You'll see here that it says the main effect of HIV infection is the destruction of CD4 helper T cells. So essentially, HIV goes inside of these cells, does what it needs to do to make a copy of itself, kills the cell in the process of that, and then a new virion emerges, and so on and so forth. And the process continues as long as there's nothing in the place to stop the replication process. When we talk about advanced disease, certainly someone can present with certain symptoms to suggest that that advanced HIV disease is present, like some of the opportunistic infections, cancers. But also, when we look at laboratory testing, we're looking at what the absolute CD4 count is initially, and certainly periodically as we're going through the process of treating someone for HIV. that initial CD4 count is certainly very important because that kind of lets us know where someone is initially in terms of the disease process. So for someone who has a CD4 count that's less than 200, usually an AIDS diagnosis is given at that time, and sometimes there are opportunistic infections, not always, but sometimes they are present. Our goal is to stop this process from happening. We want to stop HIV from making a copy of itself so the CD4 cells can live, and the CD4 count can hopefully improve and emerge, over time. So we do that by antiretroviral therapy. So this is what we need to keep HIV from making a copy of itself, to suppress the virus and ultimately improve the immune system. We have clear signs now as it relates to the transmission of HIV for those individuals who are undetectable, taking antiretroviral therapy the correct way. In that, if they are undetectable and they remain undetectable 6 months or longer, then those individuals are not transmitting HIV sexually. The science is very clear there, and so a lot of what we're having to do now is, not only educate those people that have HIV about the strength of the science and how this is life changing for them in terms of, being on antiretroviral therapy and what that means for them, but also to make sure that we educate the community, hopefully to break down stigma as relates to, people with HIV, understanding that someone with HIV who's doing the right things are not transmitting HIV. Our biggest challenge right now is identifying those people who have HIV and don't know it, because it is likely that they're the ones that are certainly transmitting HIV because they're not virally suppressed. And perhaps those individuals who may be with HIV and out of care and not on antiretroviral therapy. So challenges there certainly, but we want to make sure that we get those individuals moving in the right direction. Next slide, please. And when we talk about HIV and smoking, what's really interesting is that a lot of people smoke in the general population. I mean, even with everything that we know in terms of what smoking does. But certainly when you think about someone who is smoking and also live with HIV, we do have some pretty significant concerns. So smoking in general has been associated with nearly 500,000 deaths annually. And even with secondhand smoke, so these are people who are not smoking and they're just around and inhaling or in environments where there's lots of smoke. You can see that it contributes to over 41,000 deaths. So cigarette smoking is known to cause some pretty significant health consequences in the general population. So COPD, cardiovascular disease, cancer of the lung, larynx, neck, cervix, anus, and then also some endocrine impact as insulin resistance, metabolic syndrome, and diabetes. Then when we put HIV into this equation, it definitely can be something that causes someone to have some pretty significant health challenges and overall can be challenging to their health if they continue to smoke. When we look at HIV in terms of what it could potentially do, particularly if it's not well controlled, we understand that HIV and AIDS increases the likelihood of non-HIV related cancers due to immunosuppression and the inflammatory process that's associated with the disease process. So we're often asking people, uh, rather either if they're newly diagnosed or just in care in general and in care. That's why it's so very important for people with HIV to remain in care, is for us to monitor for any impact that HIV may be having, even in the most controlled environment, them being undetectable and doing all the right things. We are constantly monitoring and asking questions about their health and trying to identify anything that may be happening. So we're always looking at the skin. We're always looking for any lesions or anything that may be on the skin that should not be there, asking about any types of symptoms. And I usually just kind of do a run-of-the-mill spiel every time everybody comes in to see me. Look, are you having any fever, chills, weight loss, night sweats, coughing, sore throat, oral lesions, chest pain, shortness of breath, stomach problems, nausea, vomiting, diarrhea, any change with your vision, any headaches? Is there anything going on with you that should not be? Is there anything out of the ordinary that should not be? Because I'm hyper vigilant about the inflammatory processes that we know HIV causes, and I'm also hypervigilant as it relates to the increased risk of non-HIV related cancers in the population. When we think about HIV and smoking, we also have to think about some of the impact that smoking has um, in terms of these conditions that I have listed here for you. So we sometimes will see thrush or Canada of the oral pharynx for someone with advanced HIV, but it also can increase the likelihood of thrush for someone who has HIV and also smokes. Hairy leukoplakia is a concern, and we're looking for those kinds of lesions in the mouth, bacterial pneumonia. And I remember when I was in pathophysiology, we were just kind of talking about what smoking and the inhalation of smoke actually does to the cilia-like projections in the lungs. It essentially it paralyzes them, and so those finger-like projections that are kind of doing this. It's not spirit fingers, but this is me demonstrating the cilia in the lungs. They're necessary to kind of move mucus and things that should not be in the lungs along, and hopefully move them along to be expelled by a cough or whatever. But smoking essentially paralyzes that process, and so it makes sense when someone um, they smoke for a very long time, they develop what they call chronic bronchitis, and they're always coughing. Those are those individuals that get up in the morning and they're hacking, trying to get up mucus and stuff that's basically just been sitting there because that cilia process is just not working like it should. And when you think about that as it relates to the inflammatory process of the HIV, we do have some pretty serious concerns there. And then pneumonia certainly is listed there as well. So, in thinking about kind of what could potentially be happening, all efforts are on deck in terms of identifying people who have HIV and smoke and have some really serious conversations with them about the impact of the two of them can have on their health, and certainly the two of them in combination, and try to do things that are necessary to lead them towards, smoking cessation. Next slide. When we think about the impact of HIV on cardiovascular risk, remember, I made the statement that HIV has inflammatory properties and can cause, chronic inflammation, in the body. That is a process that we see sometimes that may play out in the cardiovascular system, so in the vessels themselves. And so we're constantly monitoring. There's emerging data, certainly if you've not heard of the reprieve study of the data that's there, but we are really really hyper vigilant now and having conversations about the impact of HIV on cardiovascular events. And so, when we think about the types of medication that we are prescribing for people, to control their HIV, we have to take some things into consideration because there's some evidence to suggest that, some medications may have some impact when we look at our tenofovir formulations. So tenofovir alafenamide versus tenofovir disoproxil we have to take that into consideration as it relates to what we're prescribing. We understand that, TAF has less impact on bones and kidneys, but has impact on lipids. And so when you're thinking about someone who has increased cardiovascular risk, if you have them on a medication that may be increasing, lipids for them, that may not necessarily be a good thing. That may increase their cardiovascular risk. When we look at TAF, there's been some associated weight gain with TAF. It's particularly in combination with the integrase class. So those medications that people are taking, and quite a few people are taking integrase-based regimens with TAF. We have to have conversations now about what that means for them, and perhaps really really dial up those lifestyle modifications and make sure that they understand that. There's also some emerging evidence to suggest that statin use perhaps is where we need to go with people living with HIV with cardiovascular risk, because that may have some benefit in terms of reducing inflammatory process and ultimately reducing their cardiovascular risk. To the right, you'll see, the things that we're most concerned about. So this inflammation as it relates to people living with HIV is chronic. It does increase cardiovascular risk. Now, when you think about that in combination with smoking, now here we now have a scenario now where we also know too that smoking itself increases cardiovascular risk. Not only does it increase, pulmonary conditions, but or some pulmonary pathologies, but also increases cardiovascular risk. So now you have someone who's smoking, who has HIV. HIV has inflammatory processes. The smoking itself is going to cause problems. And so we're having significant conversations now as we learn more and really, really trying to make sure that people living with HIV understand the risks that's associated with smoking, understand its association with the possibility of causing cancers, the possibility of increased cardiovascular events, and really, really hoping that we can reduce the incidence of cancer, the incidence of cardiovascular events, the incidence of any type of chronic pulmonary disease, so people living with HIV can have a life that's healthy and full. Next slide, please. So our goal is to get people on to treatment, certainly, because that's going to certainly be of benefit in terms of reducing morbidity and mortality as it relates to advanced HIV disease or AIDS. And most people living with HIV today are taking oral antiretroviral therapy, which is in a single tablet. So they're taking one pill once a day. Certainly, there's newer formulations that are out there in terms of long-acting injectables that some people are taking, but the majority of people are still on oral therapy, and it's been quite simplified, which has been very good in terms of adherence, and also safety and tolerability. If smoking is identified in the health history, we want to try to address it as quickly as possible, and talk about some treatment options that may be of benefit as we work towards smoking cessation. So again, I talked a little bit about oral tap and how it may increase lipids, but it also may have a lesser impact on bones and health and renal function versus oral TDF. So we're taking those things into consideration, but also having conversations with them about what else is available that can help to get them from smoking. Next slide, please. And I mentioned the long-acting injectable, so here we are for you to appreciate. It's interesting how with the impact on bones, lipids, renal function, those kinds of things, we are not seeing that. And so I think it's a benefit, particularly for someone who may have, let's say, a very strong family history of cardiovascular disease, that we can perhaps control their HIV with these long-acting injectable options. But, it's important in terms of how the medication is currently indicated, that people are have well-controlled HIV on their oral regimen before they switch the injectable. Although there is emerging evidence to suggest that perhaps there may be some benefit for those individuals who are really struggling adhering to oral antiretroviral therapy for a variety of reasons. But as it stands right now, the true indication currently is to have individuals undetectable or virally suppressed before they make that switch. But it is good to know if you have someone who may be at risk for some cardiovascular, renal, or bone, or whatever. We have options now that has less impact in that space. But in the meantime, making sure that people understand the importance of staying in care, because if we're able to identify any type of malignancy or cancer or anything that may be happening that's abnormal, that we identify that sooner than later, because we know that the sooner we can get someone moving along in terms of treating that, it may benefit them in terms of their morbidity and mortality. It's important for people to be monitored while they're on medication for safety and efficacy and quality of life issues. We're really working in the space of making sure that people living with HIV have good quality of life. People are living longer. But what does that look like? Are they living longer, but they have all of these aches and pains and increased risk for malignancy and cardiovascular events and all of that? Or are they living longer and we're able to address all of that and they can live a long, healthy life like the general population, but not necessarily succumbing to other significant health consequences. So lots to learn in that space, but certainly monitoring and for them staying in care is critical to make sure that we address those things as they pop up. And then most importantly, there is no evidence to suggest that the current HIV treatment options interfere with any of the medicinal treatment options for smoking cessation. So, those medications that are out there that we are prescribing, either topical or oral agents, gum, whatever it is that's available, there's no evidence currently to suggest that somehow the current antiretroviral regimens that we're prescribing are contraindicated or have any type of significant drug-drug interaction in any way. So that's very important to make sure that people understand and not only is it the medicinal treatment options for smoking cessation but it's also the other piece to that, which would be the behavioral health piece. So whatever cognitive behavioral therapy or whatever it is that's available to help to support the change in behavior for people who are smoking is also beneficial, and the literature does support that combination approach, not necessarily just prescribing a medication for smoking cessation and not addressing the behavior itself. So, next slide. All right, I'll turn it over to my colleague, Dr. Wood.
Thank you, Dr. Kendall. And again, I appreciate, thanks for inviting me to be part of the panel. And Dr. Kendall had already given me a very nice introduction for HIV and people living longer in terms of malignancies and cardiovascular diseases. So what I'm going to tell you or discuss with you in the next 20 to 30 minutes is about the changing epidemic in terms of the people living longer, a changing of HIV-associated malignancy. So I'm going to share my screen. And I hope I can share it. Let me see. Michelle, do I have the ability to share the screen? I can do that? Okay.
Yes, you have the ability to share.
Okay. Let me just share the screen. Okay. Did it come through? Everybody can see it? Great. Okay. So what I'm going to be talking about is really the changing landscape of HIV-associated cancers. It's quite different than when it was first originally associated with HIV or AIDS patients. So I'm going to cover a few areas of interest. Oh, let me see. Pressing. There we go. Okay. So there are a few areas which I'm going to cover this evening. First of all, it's about the current HIV the epidemic and the status of cancers in people living with HIV, and also about malignancies and the HIV epidemic and cancer mortality and factors that are contributing to cancers in people living with HIV, and especially the viral etiology that are associated with cancers in people living with HIV, and some of the treatment and strategies to help alleviate this issue. As you all know, that HIV/AIDS was discovered in 1981 from a report by CDC, the MMWR, is associated with a group of young adult gay men. They're coming down with a very rare cancer called Kaposi sarcoma. And it was very rare. And then they come down with also opportunistic infection like pneumocystis pneumonia. And these are young adult male with no underborn congenital reasons of getting HIV. So therefore, the whole HIV epidemic broke out in 1981. And these cancers, the associated with HIV-infected individuals, were so-called AIDS-defining cancers. Kaposi sarcoma is the first one because it was discovered right at the beginning. And other cancers was added, which are associated with HIV-infected individuals, AIDS patients, non-Hodgkin lymphomas, and cervical cancers. Kaposi sarcoma, as I said, is a very rare cancer, was discovered in 1872 by Dr. Maurice Kaposi. And it's really a pigmented sarcoma of the skin. And it's very complex. Most likely the endothelial cells are involved, and it's an AIDS-defining illness. And in 1994, in the beginning, people were thinking that HIV actually causes the cancer. But then in 1994, it was discovered there's another virus, it's a herpes virus, that is really the etiological agent for HIV, for KS. And this virus was known as called Kaposi sarcoma-associated human herpes virus. What is shown here is a very mild form of Kaposi sarcoma, but in AIDS patients that show up late without treatment can be very severe. And these are some of the patients we see in Africa, in Tanzania, and they come in very late. You can see can be oral Kaposi's, can be in the limbs and become very severe. And these are late stage, and it's very difficult to treat. And most of them actually died even upon treatment. So that's why it's important to really discover the disease and get treated early. Now, even up to now, there are millions of people dying with HIV. About 630,000 people, and over a million people still infected, new cases infected by HIV. And there are almost 40 million people worldwide that are living with HIV. So it's still pretty much with us, the epidemic, even though we don't hear about it in the newspaper and people are not so aware of the thing HIV is. It's a manageable chronic disease. It is, but we're still getting new infection, which is something very, very need to be prevented. And there are 39 million people, and most of them actually live in sub-Saharan Africa. Over 2/3 of them are mainly in the area which I work, in sub-Saharan Africa with HIV infection. And then adults and new children infected are also mostly in sub-Saharan Africa. So there's a great need of prevention of infection in those countries. So there in Africa, as good news is that a lot of these countries are reducing in terms of new infection, but they are still, including South America, there are countries that are increasing in the number of new infections, for example, Chile, and also in North Africa. And there's really a lot more work needs to be done in terms of preventing new infection, make sure that globally new infection will go down. So what is changing? The changing is because of ART, people are living longer and people are aging. And as you can see from here in these graphs, that is improving survival of HIV. And at the same time, you are seeing the increasing population that are aging. The younger people are fortunately getting less and less because of the prevention. But the people that live with HIV, you can see the majority of the individual infected by HIV are now 45 and above, and many of them are over 65 years of age. So that's why we're seeing all these chronic diseases that Dr. Kindle mentioned earlier, cardiovascular disease, premature aging, and cancers are also increasing in that population because of the elderly increasing population. So what we also see is that there's a changing of so-called AIDS-defining cancers, the Kaposi's, the lymphomas, cervical cancers, but there is also changing, increasing amount of so-called non-AIDS associated cancers. And you can see from this graph, which is shown very nicely, is that these are the people that are living older in more than 45 years of age. They are decreasing in terms of the so-called AIDS-defining cancers. But then you can see the red bars, even though number of cancer cases are decreasing overall, but the majority of the cancer cases are in sort of non-AIDS defining cancers. And so what are these cancers and why are they increasing? And this is normal because people are living longer, but they're much more so in the HIV infected population. So what are the cancers that are defining AIDS and what are the non-AIDS defining cancers? And those are the three that I mentioned earlier: Kaposi sarcoma, non-Hodgkin lymphomas, cervical cancer. These are AIDS defining, but they're also now the increasing number of cases of non-AIDS defining cancers, anal cancers, lung cancers, Hodgkin lymphoma, liver, breast, colorectal, prostate, and follicular lymphomas. And there are also other cancers that are rare, also associated with HIV-infected individuals. These include the Merkel cell carcinoma, leiomyosarcoma, and salivary cancer. So all these are much more common in people living with HIV compared to normal population. And this is an old study, but it shows that the increasing risk of people living with HIV in the US and had much higher risk of both HIV-associated AIDS-defining cancers, and now with increasing viral-associated cancers in the population. And this is even though it's back in over 10 years ago, but we are still seeing a lot of viral-associated, non-AIDS-associated cancers in the population. So how is it changing? This is a nice study published several years ago by a group at NIH, NCI. They break it down into cancers that are in the peak of the HIV epidemic, even though the ART started in about 2010, 2020, and predicting what are the type of cancers in 2020, 2030. You can see that in 2010, the so-called the AIDS-defining cancer are still very common. Kaposi's, non-Hodgkin lymphomas, and lung cancer is always there. But then by time about 2020, it's changing. We are now seeing lung cancer, prostate cancer, and non-Hodgkin lymphoma. Kaposi's sarcoma had gone down because of the treatment by ART. And the prediction is that by 2030, prostate, lung, and liver cancers are the probably most common cancers in people living in HIV. And that's the projection. It's a changing epidemic, a changing of the HIV-associated cancers. So how about mortality? Now, mortality about cancers, it is one of the fastest growing cause of death among the HIV infected individuals. And there's a decrease in AIDS-defining cancers and increase in non-AIDS-defining cancers. So cancer and cardiovascular disease, which was discussed earlier, are the leading causes of death in HIV-infected people, especially in the aging population. And there are a number of studies showing that AIDS-defining cancers are flat, and it's probably going down by now. But then the non-AIDS defining cancers that are leading cause of death of the HIV infected are increasing. So the whole epidemic is changing, and the type of cancers are also changing in the people living with HIV. So the risk of high mortality, it actually is not only associated with few cancers, but actually across the spectrum of different cancers. And you can see the mortality, because of the cancers are in blue, is much higher in the HIV population compared to the negative population. For example, liver cancers is much higher in the HIV positive individuals compared to HIV negative individual. Same thing with the pancreatic cancers. It's much higher in the HIV population compared to the negative paper. So you can see across the spectrum of most of these cancers, the HIV infected individuals are at much higher risk compared to the normal population. So what are these? You can see again that the HIV AIDS defining had gone down since the mid-90s, and it's changing. These are the non-AIDS associated malignancies, and the infection associated cancers are also still there. So I'm going to tell you a little bit more about the type of infection that are associated with cancers. So in general, what are the factors that are contributing to increased cancer cases and mortality? And people are living longer, of course. They're not dying of opportunistic infection, but they are dying from chronic diseases, premature aging, chronic inflammation, cardiovascular diseases, and cancers, and especially in older population, an increase of age in cancers, much more so than in infected individuals, and a fourfold increase in the population in general. And as was discussed earlier, and there seemed to be a greater and earlier start to smoking in the HIV population. So that also would lead to cancers and other diseases. And substance use is another potential factor that affecting the HIV infected population. So, and in addition, there are these immune dysregulation that was pointed out earlier. These are people going through chronic immune activation, chronic inflammation, and having a slightly lower CD4 counts. And the T cells, even though the numbers had gone up upon treatment, but they're still not probably not perfectly normal because of chronic immunosuppression. And all these factors contribute to immune dysregulation and leading to cancers. And in addition, oncogenic viruses, such as Epstein-Barr virus, Kaposi sarcoma virus, herpes simplex virus, papilloma virus, hepatitis, HPV, HCV, and also cancers. And in addition, the additional factor, which are probably non-biological, and such as people are advanced stage at presentation, as I showed you earlier, in some of our clinic in Africa, people coming down with really glaring diseases before they show up in the clinic for treatment. And many of them don't even know the HIV status. And also inadequate treatment in some of the cases, inadequate supportive care, lack of access to clinical trials, that is still a problem. Many of the clinical trials are not accepting HIV-infected individuals, even in cancer trials, because the trials, they think that HIV-infected individuals are different, they're going to have more complications. So most of the time, they are not included in clinical trials. And hopefully that will be changing. And people are now providing data that clinical trials, HIV positive patients are as good as the non-HIV infected. So I hope this will be changing with time, and they tend to be using less aggressive because they worry about HIV, and there are other factors, lack of coordination between cancer care and HIV care. And we see that in New Orleans here. For example, our cancer registry are not linked to the HIV registry. And so there need to be a better linkage between other diseases and HIV. HIV doesn't stand alone, but it's to be linked to other cancers and other registry as well. They need to really have multidisciplinary support, not just for HIV treatment. And because of all this aging population, all these other diseases, and stigma, believe it or not, is still there in the population. Pretty much so in Africa, and even here in the US and in Louisiana as well. So people tend to be a little bit more reserved if they're being carrier, and they're not being treated properly because of the stigma of HIV infection. And so these, unfortunately, disproportionately affected the underserved population, those that don't have the means to seek proper health care, and they have worse outcome, and in some of the cancers because of late presentation, advanced stage, poor access to care, the medical comorbidity, and toxicity upon treatment. So we really don't know if HIV had adverse effect on cancer behavior, not necessarily immunologically or clinically, but indirectly through behavior and to affect them in terms of seeking proper care. And also there are limited data in guiding cancer treatment in HIV-infected individuals. So again, there's a disconnection between cancer care and HIV care, which really needs to address. So what are some of the biological factors that affected HIV-infected individuals, people living with HIV? Viral co-infections, and this is a topic very close to my heart because these are agents that we can try to address and prevent so that people living with HIV do not get those cancers, or in the general population in general. And some other factors are immune deregulation, inflammation, and oncogenes that are associated with cancers that could be reactivated, affected by viral infection, genetic instability. You have so-called epigenetic changes in HIV-infected individuals, especially as they grow aging, and increases susceptibility to carcinogens. And we have lots of those in southern Louisiana here. And abnormalities because of facility of cells because of HIV infection and could cause cancer development, such as epigenetic changes, and population differences that could also be contributing to cancer cases and susceptibility, exposure to carcinogens. All these biological and non-biological factors really contribute to the increase in cancer as people living with HIV, especially when they're surviving longer. So let's forget that. So there are lots of evidence saying that immune perturbation because of HIV can increase cancer cases. And the risks are there are differences in different cancer patients, but co-infection has the strongest association with HIV-infected individuals because they are more susceptible to other viral infection, hepatitis, papillomavirus, and even people with normal CD4 counts are known to have higher risk for cancers because, as I said, they have chronic inflammation. T cells are not necessarily normal because of long-term HIV immunosuppressions. So all these risk factors have increased with number of studies showing that both breast cancer, prostate cancer, colorectal cancer, ovarian cancers, and even in lung cancers, you have higher risk in HIV-infected individuals. So what are some of the predictors for cancers? One, the CD4-CD8 ratio tend to be a very useful predictor of people with HIV. If you have lower CD4-CD8 ratio, you have much higher risk for cancer development. Some of them are normal, but most of them stay low. And it is a strongest immunological prediction for lung cancer in people living with HIV. So keep in mind, CD4-CD8 ratio is still very important in terms of the predicting factor for cancers. So viruses, and I've been mentioning that, many of these cancers are associated with virus infection. Kaposi sarcoma is linked to this herpes virus. Non-Hodgkin is linked to EBV and possibly the Kaposi sarcoma virus as well. Cervical cancers, papillomavirus is well established. Anal cancers, again, papillomavirus. Hodgkin disease is also the EBV. Leiomyosarcoma, especially in children, they also EBV infection. Squamous cell carcinoma, papillomavirus. Merkel cell is another polyomavirus, Merkel cell cancer virus. And hepatoma, HCV and HBV. Merkel cell, I think, is polyomavirus. So all these are cancer-causing viruses that one can prevent if we could. So what are some of the treatments for cancers? And as I said, HIV is independent risk factors. Again, HIV infection, people living with HIV, is not a reason for going through less aggressive cancer treatment. Many of the oncologists will shy away from the most aggressive cancer treatment because they think that this individual will complicate the HIV disease, which is turned out to be not the case. And oh, sorry. And they do not get the same type of cancers, but they actually should receive the same type of treatments. And cancer treatment should be treatment-related toxicity are due to anti-cancer agents, not because of HIV. And again, people worry about this complication, but it's same as normal individuals. And cancer care should involve an oncologist, a team, an HIV infectious disease individual, and oncologist. So, and the pharmacist as well is also very important. So this has to be integrated in terms of treatment, not just by HIV infectious disease individuals or by oncologists. So they should really interface with each other for treatment. So what we need to do is to make sure, first of all, the individuals are adhered to ART, which is becoming not a major issue, and should address some of the behavioral associated risks, such as smoking, alcohol consumption, drug use. All this need to be addressed. And screening, I think that is the most important. Cancer screening, not only by oncologists, by the HIV clinician as well. They got to also do cancer screening at the HIV clinic. And of course, prevention. And it's well established that the papillomavirus vaccine works. So you encourage people to take vaccination in terms to prevent papillomavirus or to prevent anal cancers or even cervical cancers. So screening and vaccination, I think those are the key to prevent or to reduce non-HIV associated cancers, and screening for breast cancer, cervical cancer, colorectal, lung cancers, and at an earlier stage when it's discovered. If the earlier they discover, the better is the outcome for treatment, as we all know. And this should be, anal cancer should be screened, and this should be really questions whether to be a standard of care. And there's a really well-studied clinical trial showing that early cancer for anal cancer and treatment can really prevent disease, become untreatable cancers. Vaccination is really key. And for HPV vaccination to prevent anal cancer, penile cancer, vaginal cancer, vulval cancer, maybe even head and neck cancers, and all these HPV-associated cancers can be prevented by vaccination. So this needs to be encouraged. So these are the kind of strategies that one take to prevent and reduce non-AIDS-defining cancers. So in conclusion, I want to say that the epidemic for cancer is changing in the HIV-infected population. You're seeing a reduced risk for AIDS-defining cancers such as Kaposi sarcoma or even cervical cancers in the US, but it's still a problem, major problem in Africa. And despite the successful ART, they are particularly risk. People living with HIV are at risk for infection-associated cancers because they're more susceptible for infection, including cancer viruses. And the aging population are more susceptible to non-AIDS defining cancers. And now it is a leading cause of death in people living with HIV, especially in the aging population. So with that, I will be happy to answer any questions, and thank you very much for the attention.
Thank you, Dr. Woods. If you don't mind, stop sharing your
Harry,
screen.
yes, stop that. Okay, great.
All right, and then we're going to have Dr. Burgess come on next. Let me get my screen together. Okay. All right, now we'll have Dr. Samuel Burgess continue our discussion today.
Thank you very much, and it's a pleasure to be here this evening. I'm going to talk just a little bit about syndemics. So I know we're focused on HIV and smoking this evening, but I take every opportunity to also talk about the intersections of other STIs and hepatitis and how those epidemics impact the same or very similar populations in the US, in the world, and certainly here in Louisiana. So I'm not going to go over epi slides in great detail, but what I want to point out with these first several slides is just who the people are that are disproportionately impacted in our state. And when we talk about health inequities, we're talking about the communities that are disproportionately affected by a particular condition, in this case, HIV, STIs, etc. But that disproportionality is rooted in stigma, discrimination, and social injustice. So it is not inevitable, it is not random, and it is, in fact, evidence of social discrimination and injustice. So that's what I mean when I say inequities in healthcare, or specifically related to HIV and STIs. So as you'll see here, nearly 60% of our primary and secondary syphilis cases are among Black people in Louisiana, 2/3 among men, primarily gay and bisexual men, followed by Black women. Next slide, please. And these are just trends over time. And so unfortunately in Louisiana, like most places in the United States, syphilis has been on the rise. We may see a little bit of a stabilization in the last 2 years, but still alarmingly high numbers. Next slide, please. Congenital syphilis, this is when a pregnant person has syphilis during pregnancy and is not treated timely prior to delivery, and or an infant is born with syphilis that they received from either before or during birth. Louisiana has high rates of congenital syphilis, but again, what I want to point out here is that 60% of these congenital syphilis cases were among Black pregnant people, and we have one of the highest case rates in the nation. Next slide. These are trends of congenital syphilis over time. Next slide. I'll also point out, as Dr. Wood talked a bit about, people with HIV sometimes not receiving the most aggressive or perhaps the latest care for cancer. We see that substandard care is a contributing factor to congenital syphilis cases as well. So timely, the majority of people related to a congenital syphilis case had adequate prenatal care, but did not receive appropriate screening and or treatment in order to prevent the congenital syphilis case. Next slide. This is gonorrhea in Louisiana. And again, over 70% of people diagnosed with gonorrhea in 23 were Black. A little closer to a 50-50 split, but men about 55%. And again, we see the majority of these cases among gay and bisexual men. Next slide. These are gonorrhea trends, and we're beginning to see nationwide some declining cases in the most recent years, but still alarmingly high levels. Next slide. This is chlamydia, and this one, similar trend in terms of majority of people diagnosed are Black in our state, but we do see more women diagnosed with chlamydia, which is unique among the STIs that I'm talking about this evening. but that is a function of not having a screening recommendation for men. So, obviously there are probably quite a few undiagnosed men with chlamydia in our state as well. Next slide. These are chlamydia trends. Very high case counts here. We're talking over 36,000 cases in 2023. Next slide, please. And this is just a comparison of the most recent years for which we have national rankings. And actually, I think the 2022 rankings just came out a couple of weeks ago for the nation. We have 2023 data on many of these slides, but we don't have national rankings for that yet. But you could see, unfortunately, we're in the top 10 national rankings in Louisiana for almost all of these conditions. Next slide, please. And now looking at HIV diagnoses, again, very similar trends here. Almost 70% of cases among Black people in Louisiana, and about 75% of those are men. The vast majority are gay and bisexual men. So the populations most impacted are Black, gay, and bisexual men, followed by Black women, and then white and Hispanic, gay, and bisexual men in our state. Next slide. So unlike some of the other STIs, people newly diagnosed with HIV have been decreasing, or we've been seeing a decreasing trend overall over the past several years. A little bit of a blip during the COVID years and following, but it seems that we're resuming a downward trend, which is a good thing. But of course, our local and national goals are to really reduce these numbers down to zero or near to zero. We have all of the tools now, HIV PrEP and PEP, highly effective treatments for people living with HIV. And we know that when people living with HIV maintain viral suppression, they're unable to transmit HIV to others. So we really have a plethora of social and biomedical interventions now that we could really eradicate HIV if we had the political will and resources to do so. Next slide. This is acute hepatitis B. And again, just pointing out here, the same populations, Black people, and when it comes to hepatitis B, we are seeing more females. And again, that's probably a function of more screening for hepatitis B during pregnancy compared to males. But again, Black people predominantly impacted by hepatitis B in our state. Next slide. And then chronic hepatitis B. And here you see slightly more men diagnosed than women, but again, primarily Black people in Louisiana. Next slide. And then we have acute hepatitis C. Similar picture, except that this is one of the few STIs that we track closely where white people outnumber Black in terms of new diagnoses. And next slide will be chronic hepatitis C. And a similar case there, majority of chronic hepatitis C cases also reported among white individuals, with the majority being men. And so the takeaways I want the participants to have from that is just that these are conditions that are impacting the same or very similar populations. And again, they're rooted in social inequities and intersecting identities. So we certainly see the most at-risk groups being those that have multiple historically marginalized or discriminated against identities, such as being Black, gay, and bisexual, for example, or being a Black woman as another example. And so it's really those groups that bear the brunt of these conditions, and that's where we come with the term syndemics in terms of how we approach them, how we think about them, and also what do we do to help support people and address these problems. Next slide. And so I'm not going to go in detail about all of the different public health interventions that we support through the Louisiana Department of Health, but I will just highlight a few, and I'll also point out that we don't do a whole lot of work directly, but what we do is provide resources to community-based organizations, to community health centers, hospitals, correctional facilities, schools and universities, some religious groups, etc., who really do the frontline work in working with these communities. And a lot of that is because of the historical injustice that these populations have experienced and the importance of working from within their own communities to address these problems in ways that are meaningful to them. So I always start by talking about capacity building, and that can sound cliche or old and tired, but really what I want to focus there on is we require all of our health department employees as well as our contracted staff at organizations to study racism, race and racism, homophobia, transphobia, and behavioral health and destigmatizing drug use. And those are some of the required capacity building courses that our workforce participates in because, again, of the history of injustice that has led us to where we are with these rates today. So I definitely want to point that out. And certainly substance use and STIs go hand in hand. That's always part of the conversation when we're talking about syndemics, and certainly smoking is included in that. Of course, we do a good bit of social marketing. I certainly elevate our LA Health Hub, lahhub.org website. You can find all sorts of statistics there in addition to the ones that I've shared this evening, as well as a lot more information about these various interventions and contact info in case you want more information than what you find there. We operate statewide harm reduction services, including syringe service programs and the distribution of naloxone, fentanyl test strips, wound care supplies, etc., for people experiencing substance use disorder. And there will even be some vending machines in some select locations across the state coming very soon. We are currently working on pharmacist-initiated HIV, PrEP, and PEP that will allow pharmacists in Louisiana to be able to administer or dispense PrEP and PEP meds without other prescriptions. So we're very excited about that. It should be happening within the spring of next year. Next slide. And a lot of the interventions that I think most effectively address endemics and the intersectionality of the disproportionately impacted populations, or trying to meet people where they are, understanding the barriers that they face in their day-to-day lives, and bringing services to them or making them as low barrier as possible. And so things like bringing syphilis treatment directly to people's homes, because understanding that childcare, transportation, et cetera, can be barriers sometimes to getting that timely treatment. Shipping bicillin to provider offices from our public health pharmacy, because some providers are reluctant to stock it. It's expensive. It has a short shelf life. They need shop carts, et cetera. So again, just trying to identify where the gaps are in service delivery and address those. Offering case management services to pregnant people diagnosed with syphilis to make sure they are linked to quality prenatal care and receive timely testing and treatment for syphilis. And partner services, of course, is a staple of public health work. Next slide. Increasingly integrating the services. So again, that syndemic approach that I've been talking about, but we're really not interested in just having an event where only HIV testing is going to happen, but we want to offer a full array of sexual health services, and whenever possible, whole person services. So supporting, health fairs, having community health workers distribute information about food banks and rental assistance programs, all the things that people need that are above and beyond their specific sexual health needs, but certainly trying to provide as robust sexual health services as possible wherever possible. We have linkage coordinators who work with people who have fallen out of HIV care. There's and also hepatitis C care, making sure that we offer them linkage support, and that can look like transportation assistance, referrals to other providers. Maybe they had a bad experience at one, they're interested in another. And in some cases, they need help getting documentation, enrolled in Medicaid, enrolled in HIV assistance programs, et cetera. And so our linkage coordinators offer those services. I'm very proud of a program we call Health Models that provides financial incentives for people for staying in HIV care, and the largest financial incentives for achieving and maintaining viral suppression. I would note that that program also does provide smaller incentives when their provider refers them for other needed services, which can include substance use treatment, smoking cessation, and other things that are, sometimes tangential, but very important to their overall health care. Rapid Start program. So, of course, our goal is to get people diagnosed with HIV, linked to care, and started on ARVs as soon as possible, the same day, if at all possible. Next slide. And then, of course, like many jurisdictions, we operate the Ryan White funded, what's often called AIDS drug assistance programs. We call ours the Louisiana Health Access Program, or HAP, but it provides HIV medications. And actually, more commonly, we provide full insurance premium. We pay premiums for people living with HIV to have full healthcare insurance versus only providing HIV meds, because again of that syndemic approach, and we know the intersectionality of social identity and health outcomes is so important that full insurance certainly gives our populations the best chance at a healthy life than only if we were to provide HIV meds alone. We have an open formulary, and that includes smoking cessation and also all cancer treatment drugs. There's housing supports, and then case management, and lots of the social supportive services that I've already been speaking about that are specifically available to people living with HIV. Next slide. We also have a teleprep program, and again, in that vein of trying to meet people where they are, this is a program that allows individuals in Louisiana to access PrEP services no matter where they live, and as long as they can have access to a telephone or a laptop, then they can get hooked up with the teleprep program. I think I mentioned before community health workers, but they really are a very important part of the work that we do. And they're going out into communities. They are members of the communities in which they work, but providing health education, home test kits in some cases, offering testing in community venues, harm reduction supplies, etc. And then I definitely want to lift up our wellness centers. These were really started over a decade ago now, but to primarily address the specific needs of gay and bisexual men living in rural areas in Louisiana, where they often didn't feel comfortable discussing their sexual orientation or the specific needs of their sexual health care in traditional clinical settings. So these really got their start that way and have endured for quite a while now, but they are driven by steering committees of people receiving services at the centers, and they choose their own supportive programming. So they offer sexual health services, of course, screening and treatment for STIs, etc. But they also do lots of additional things. So some of them will do physical fitness classes. Some of them offer smoking cessation classes on a regular basis. And we certainly promote vaccinations that are recommended by the CDC for gay and bisexual men to make sure those are available in these centers as well. Next slide. And that is it for me. Happy to take questions at the end. Handing it over to my colleague, Mr. Morris Singletary.
Thank you so much. It is amazing to be here with all of these amazing speakers and who have made my job easy as we come to the end of this. And we are speaking about advances with HIV smokers and tobacco. We've already talked about what HIV is, and we've talked about how it affects the body. HIV-infected smokers are at relatively higher risk of cancer than HIV non-smokers, right? 42% of people who are living with HIV are smokers. And that's it's pointed out in many numbers or many studies that show the kinds of cancers that people are related to, which are lung, head, neck, esophageal, anal, and cervical cancers. Next slide, please. High risk. Several reports suggest that smoking is a risk factor for cancer development in people living with HIV. This study was done in 2018 and pretty much has not changed. As we can see, 23% of the cancers of in HIV-infected populations were related to those who were smoking. Next slide, please. Cancers. Cancer risk in HIV-infected smokers. One out of two people living with HIV who smoke will end up with cancer, unfortunately. They have an 18 times higher opportunity to get cancer than those who do not. And about 3.8 times higher than those who quit smoking at the age of 40 to 35. Next slide, please. One thing I want to mention that I did not put in this is I did not want to just say smoking. And I know a lot of times when our younger population is thinking about smoking, they do not consider vaping for some reason, right? And so I want to mention that vaping is super, super important when we talk about smoking, because those same additives or those same addictions are in vaping as well. Out of the 1.2 million people that are living with HIV, HIV, again, we said 34 to 47% are smoking cigarettes. The remainder of them are doing vapes, right? Lung cancer is the leading cause. Again, lung cancer is the leading cause. There is cervical, there is anal, there is some other ones, but lung cancer is the leading cause. Remember, we talked about the inflammation that happens with HIV. That's one of the major areas where that takes place. And while tobacco has been on a decline in most high-income countries, and that's the United States, there are low to middle-income countries that have not declined. In fact, they are increasing when it comes to cigarette smoking. The prevalence of cigarette smoking and the high incidence of tobacco-related cancer and other smoking-related diseases among people living with HIV are calling for a swift action to intervene with all populations. The NIH is looking to fund different ways and different places to put money into areas, especially with our low middle to income countries, where smoking has increased instead of decreasing like it has in the United States. Next slide. Awareness. Dr. Burgess just went over a number of things that we're doing here in Louisiana, starting from LouisianaHealthHub.com all the way to our wellness centers, which address things that are more than people that are living just with HIV. They are entire people, and their entire body needs to be looked at from head to toe. A lot of times, especially in Black and brown communities, we know that when people start to smoke, they're related to stress. So what are our stress reducers that we can use to make sure that people are not turning to smoking and turning to other things such as exercising, maybe eating better? Those are the things that the NIH is funding. They look to be doing those in low to middle income countries now, but it is picked up more in the United States. Next slide, please. Before I end, We want to talk about patches. We want to talk about gum. We want to talk about all of the things that people are now using to substitute their smoking, as it is now seen that lung cancer, people are realizing that is now tied together. It's not a one-off. They realize that the more they smoke, the more that their bodies will deteriorate. And so the following things, again, nicotine patches, gum, inhaler, lozenges, and nasal sprays have been encouraged. There are not at this time any specific commercials or campaigns that say stop smoking for people that are living with HIV, but we are looking for those to take place, other than those the side additives that they put on the cigarettes that this could lead to death. All those the small fine print that they add on those things. Coming at the end has been very easy because these wonderful gentlemen have been amazing with putting out stats and numbers. So I won't repeat them, but I will say, as a person that's living with HIV and who has a social circle that he has seen smoke cigarettes and also then get diagnosis of other cancers, people begin to see hindsight is 2020, right? And more than anything else, we talk about storytelling. Storytelling from people who are living with HIV and cancer has made a huge difference personally, but I've seen other small groups where people have stopped smoking due to the life experience that has been shared by those who are living with HIV. Thank you.
Thank you, Morris. Thank you, Morris Secretary, for that. Thank you to all of our presenters. I'm now going to start our Q&A. Those of you that's online that have any questions, please put it in the chat. To get us started, I will start with a question to all of you. You all can answer all at once, or well, not all at once, but it's probed to all of you. The first question is, how can public health professionals better address the compounded risk of tobacco use and cancer among individuals living with HIV?
So
Anyone can answer.
yeah,
Okay.
I'm gonna respond first because I actually have another obligation that's gonna be starting in about 5 minutes. So I'm gonna take this question, then I'm gonna hop off. I apologize. But one of the main things that I think is important is that, when someone comes into care, it's important for us to address that immediately and head on. As we're getting the health history and we're having conversations about, what's going on with them, I think it's important for us to really identify that they are smoking, how long they've been smoking, and really talk to them about what is available to help them to quit. Our public health colleagues can really help us in terms of education, health promotion, help ensure that, in whatever space that they're working in, either with their colleagues or with students, to make sure that, everyone is fully aware of the impact of smoking as it relates to, serious health consequences for people living with HIV. Those of us who are clinicians and taking care of people, certainly we need to be more aggressive in terms of what's available to help to lead to smoking cessation, and really, holding patients accountable in that space, I think, and recognizing too. I remember we did a talk like this about a year or so ago, and a colleague from LSU mentioned that people smoke for many reasons, and then they also quit for many reasons. And so I think it's whereas you may not get the impact immediately, I think it's important for just to continue to have that conversation. Hey, I know we are, every little small step is a good step towards smoking cessation, and not just, thinking that someone's going to be able to stop cold turkey, or just, are going to be able to tolerate, medications like Chantix. We have to really be very strategic and patient as we work towards smoking cessation among people living with HIV. Thank you.
Thank you, Dr. Kendall. Is there anyone else who would like to respond?
I did want to, just comment. Dr. Wood mentioned that we should do some registry matching, and I completely agree with that. And I don't see any reason why we can't make that happen. It's definitely long overdue. Because I'm a firm believer in using the data that we collect on people for the betterment of them and society. And we have good data on HIV. We have good data in the cancer registry. So let's match it up and get a better picture of where we really need to hone our efforts in Louisiana specifically. I think using the data we have is definitely a step in the right direction.
Thank you.
Yeah, let me jump in as well. So I think, as I mentioned, I think need to be comprehensive care. It's just not HIV care. I mean, it has to be really different aspects of the health of the HIV, people living with HIV. So, I mean, tobacco cessation education is part of the care. So as cancer screening is part of the care. So all this need to be integrated as a package rather than isolated infectious disease stuff, looking at giving you taking blood to CD4 counts, viral load, and then giving prescription. I think that's to be more than that. And we see that especially in Africa. There are so many people coming in, standing in line for HIV clinics. All they care just prescribe drugs. They really don't have the proper care for each individual. So I think we got to do a better job here in the US in terms of comprehensive care for people living with HIV.
Thank you. Thank you. So speaking on society as whole and some of the prevention efforts, the next question is, what are some effective community-based strategies for improving HIV and STI prevention in high-risk groups, particularly those facing social and economic barriers?
Hey, I like to take this one. A lot of times we know our sexual health and we know what is what. It's the social determinants of health that lead us sometimes in directions where, unfortunately, we're put in positions where we are subjected to HIV. If you give me somewhere to lay my head, then I'll think about PrEP, right? If I have proper job training or if I have some other things that take care of me in a financial way, then I'll be able to work and live a life that does not require me to do some things that may be strange for change, right? And so when you think about those things, that makes life a little bit easier to now think about my sexual health. Sometimes my sexual health is the thing that got me to a place to lay my head. And so with that in mind, I think that the better way to attack sexual health is by looking at entire health. I know that was said earlier, looking at the total person from head to toe, what I think is a better way, is the future way. Especially here in New Orleans and Louisiana, this is a very status neutral place. People like to be spoken to together. No one likes to be ostracized when they're speaking about their sexual health. So I think that when we speak about it all together, that makes people feel more community and they can move in a community way.
Thank you. Would anyone else like to answer that question?
I couldn't agree more with what Morris said. And I'd add that our funding is so lopsided when it comes to HIV work. All of the resources are on the treatment side, and we don't really have prevention resources, or certainly not sufficient prevention resources. And so, like Morris was saying, the same person who is at risk for HIV may later be diagnosed with HIV without the social supports and interventions needed. And it's only after diagnosis that we then have the resources to provide those kinds of supports and services, which really, is a modern tragedy, because if we could provide the same kinds of social supports, transportation, housing assistance, et cetera, before a person's diagnosed with HIV, then we certainly would go a long way in preventing and eliminating HIV.
I think better promotion education is still needed for prevention. And as I said earlier, people not aware of HIV still within the population. They think it's a cure. I mean, you just take drug and you're fine. But it's more than that. It's a lifelong chronic disease which is going to affect you as people aging. So got to be doing better promotion, and not enough effort nowadays in terms of promotion and education about HIV prevention, especially in the high-risk population. I think that needs to be addressed especially in our setting here in Louisiana.
Thank you. Thank you for your response. As we've been talking about the intersectionality of cancer, we're talking about tobacco and HIV/AIDS and the other cancers that we know that it all causes. The next question it poses, given the strong link between tobacco use and cancer, what are some policy changes that could reduce tobacco use and its associated risk among populations impacted by HIV?
Well, I love what Morris said earlier, like we can't just, it's not enough to say, smoking's bad, quit smoking, it causes cancer. I mean, we've been saying that for decades, but we have to provide alternatives, right? And I think Morris said it very well. So not to repeat your words, but people smoke for a lot of reasons. And so we need to figure out what those reasons are and then help with an alternative to replace the smoking behavior. And that's going to require an investment of resources, but that's what needs to happen.
I'll never forget walking home from middle school, and there were two guys in front of me that walked from middle school as well. And we got to our apartment complex, they pulled out cigarettes. We were 14 at the time. I never knew what even go get a cigarette other than for my grandmama at some point at the corner store. But how could a child get a cigarette? Let's more get a lighter to light it up. And him and someone was smoking in front of me. This is at the age of 14. If we look now, we know that 13 to 24 or 13 to 20, 13 to 24 are the highest ages for new incidents of HIV, right? There is clearly a correlation that our children are growing up faster than they should be, right? And that starts from cigarettes, which have been easier to get by maybe sneaking out of somebody's mom's purse or something as simple as that. I think that we should look at policies on, I remember going to Walgreens and how they have everything locked up. I don't think cigarettes are locked up tight enough. I don't think vapes are locked up tight enough. I see more kids with vapes than I do books, right? And so it makes it accessible. The accessibility of tobacco is sometimes easier than food. And I think that if we change the policies on making things more accessible that we need, the things that we want may fade away.
Yeah. So I think, as I said earlier, the integrated care is really important. People getting PrEP, getting ART needs to be really educated and assessed for tobacco use to reduce the risk. They got to be all in one package. Because as Morris said, they smoke because of various reasons, stress, everything in the population, in the people living with HIV. So something has to be done to educate that population. They're already infected. The risk is going to become higher if they smoke. And that has to come from the health package, providing an alternative for cigarette smoking, and also learning the risks of these facts about cancer and cigarette smoking. So not only cigarette, but other drug abuse as well. And as we well know that in Louisiana, and you see, the cannabis use is all over the place. All this is going to increase the risk of high-risk behavior. And so all these need to be really conveyed clearly, education and HIV risk. So again, I think comprehensive care and education is really key to me in terms of preventing all these cancers and other type of diseases associated with HIV.
Thank you. This next question I'm actually posing to you, Dr. Wood. We talked about the different stressors and how most people, they will choose what they need, the necessity that they need at that time over what we're trying to do of help to help them better their health. This question is, how does your research address mental health or substance use within the context of HIV prevention And what strategies have you found effective in supporting these intersecting needs?
Well, I think mental health has been really ignored in the HIV population, and we're just starting to try to find the extent of mental health, especially in the underserved population. And they're already stressed enough because of their financial situation, and especially when they diagnose HIV, not knowing the future and how it's going to affect their health and their income, so on and so forth. So people, again, has to be assessed for mental health in a comprehensive package when they come to HIV clinic. And it's not being done. So yeah, I'm glad you brought it up. I think mental health, we know that it's really an important risk factor. And especially, we're starting to look at that in Africa in our study, especially in women. And knowing that setting, women is already under stress or being is in men's world in Africa. And if they come down with HIV, their mental well-being is really dramatically affected. And so we try just the beginning to assess the mental health of the women living with HIV. And I think mental health is a huge issue of increasing risk behavior by the people with HIV. So I think that's an area which needs to be really looked at.
Thank you. Thank you. And I totally agree. As someone that is going to school right now as a master's of social work, I see that as a need as well, just in some of my research that I'm doing for school, that is definitely a need with everything, with no matter what you're going through in life, from substance abuse to smoking to anything. Mental health is something that no one actually puts on the forefront. They put everything else before they put that part, when that's also, to me, is a form of self-care. Now moving a little bit, switching gears, I'm going to pose this question to Dr. Burgess and ask, what are some of the most effective public health interventions you have seen for reducing HIV and STI rates? And how do these racial and economic, how do these address racial and economic inequalities?
So yeah, I quickly tried to touch on some of that in my remarks earlier, but I'll elaborate. So I because of the intersectionality and who is most impacted by HIV and STIs, and again, we're talking about Black gay and bisexual men, Black women, white and Hispanic gay and bisexual men, and of course, even within those identities, we're not talking about monoliths, right? There are different subgroups, there are differences from one area of the state to the other, and certainly from our state to the next. But one commonality is in Louisiana is also poverty, and that sort of is a risk factor in and of itself. And then if you add, low socioeconomic status on top of having a marginalized, historically marginalized, discriminated social identity, then that's where you see the worst health outcomes and the most risk for additional infectious diseases, HIV, et cetera. So the programs that have been the most effective here have been those that really meet people where they are, and they're providing, in many cases, financial and economic relief. They're providing housing support. They're helping with paying electric bills, child care. So a lot of the Ryan White services are great examples, and I think you'll often find the Ryan White program in general held as a success story in terms of addressing health inequities, because it really has provided those kinds of social supports for a very long time. In terms, though, of preventing, the resources just aren't there. So we try to emulate those kinds of services as much as we can. Case management programs for pregnant women with syphilis, for example. But we don't have the resources to be able to provide the same kinds of housing assistance or rental assistance, utility bill assistance, et cetera, that we can in the Ryan White program. So I think our limitations are are financial, and of course, the finances are controlled by political will, right? But I think when we're able to provide economic stability, we see that people are able to prioritize their health, and they do. And we see racial inequities, for example, diminish when we're able to do that.
Okay, thank you, thank you, thank you. Thinking of the prevention efforts from a community standpoint, and just from somebody that's also living with HIV, I'm gonna pose this next question to Mr. Singletary and ask, how can health practitioners better support tobacco cessation, cancer treatment, and HIV medication treatments efforts among people living with HIV, particularly those who may face multiple health and social challenges?
Thank you for that question. I'm your contestant number 4. So when I think about that, one thing for certain, two things for sure, in the over 40 years that HIV has been here, is that the science works, right? So we often say that men lie, women lie, but numbers don't. And if that's the case, let's show if the science is working for HIV, then and if it's not as strong with cancer, then baby, take your chances on HIV, right? But also that's preventable, which means if the science works, let's get to the science. And sometimes people will say that education on many levels may not do, but we know one thing for sure, that water comes in 3 forms: liquid, gas, and solid. If we start with that, we can show people what they already know and build their hope in science. I think that sometimes we don't use our most simplest forms to help people with some complex things, right? And I think when we start to educate people on another level that shows them what they already know, they will go with that, right? That's what I think that community does. If we take what they already know and then build upon it, right? And so if I tell you that the science works and you know someone who's been living for 18 years with HIV, well then, how did you do it, Morris? I took my meds. Wow. Well, how you don't get lung cancer? I don't smoke. Right? The simplicity of that just works really easy, right? And I learned that from my niece, who told me, I was in the hospital. She says, Uncle Morris, if your medicines work, take your medicines. That changed my life. That 9-year-old girl at the time told me what doctors and my mom and family have been telling me at that point for 10 years, right? Simply take my medicines. They work. Don't smoke. It gives you cancer. We have family members who have passed from colon cancer, from lung cancer. We have let's say COPD. We have people who we see the commercials. We actually know the commercials by heart because they play them. So it's not that they don't know, it's that maybe the realization of the knowing has not gone hand in hand. And I think that we could possibly do a better job by, again, storytelling. Somebody's story will do better than someone sitting in a class. And I think that that's where we maybe can start and maybe where we can continue.
Thank you. Thank you for your response. Did anyone else want to elaborate on a question that was already posed or from someone else's question before we move on? There's no questions in the chat. Okay. Okay. All right. So this is the end to our Q&A session. Again, thank you, speakers, for all of your responses and your participation in today's webinar. And in conclusion, again, this webinar was to bring awareness, education, and also just to learn about more of the studies that's happening and research that's happening and the available resources that's across the state of Louisiana to those of you that have been watching, and then those of you that will be watching this recording on YouTube. Again, thank you to our speakers for speaking today. All your information was very important and very vital. I am blessed to be in the presence of you all and all y'all knowledge. Thank you so much. For those of you that have attended this webinar that are receiving CEUs, Continue Education Units for Social Work or CHES, please answer the survey that will prompt after this webinar and also in the follow-up email, again, this webinar is recorded and it will be placed up on Tobacco-Free Living /Empower website and on our YouTube channel of Healthier Air for All. Again, thank you all this evening for joining us. And again, thank you to our speakers. And I hope you all have a good evening. Good night.
Thank you. Good night.